Welcome back, fellow mitochondriacs, for another episode of Cancer as a Mitochondrial Metabolic Disease. We're going to be continuing our discussion, knocking off every single step of glycolysis, one enzyme, one pathway at a time. And in the last video, we, on this slide in particular, talking about inhibitors of the enzyme PFK. And just so we can all be on the same page, PFK is what converts fructose 6-phosphate to fructose 1,6-biphosphate. And it is a key enzyme in the process known as glycolysis, which is hijacked by cancer to create the Warburg metabolism, or the Warburg effect, or as Dr. Seafried likes to talk about, substrate level metabolism, or substrate level phosphorylation, excuse me. And one of the PFK inhibitors that I was able to talk about was aspirin, and where it could have a fairly profound effect on PFK. And this is one of the big reasons why I love our audience, because I have a lot of smart people in the audience who challenged me in particular about the role of aspirin because of the concentrations that were studied in the particular papers that we pulled, which were basically in vivo or in vitro models where it had profound effects. And so I wanted to, before I go into our next enzyme, I wanted to talk about a little bit more about aspirin and what we know, and kind of some more gestalt clinical outcome things as well, which I did not get into. I was particularly into the mechanism of how it could potentially work and how it could potentially be combined with other things to lead to hopefully a positive clinical outcome. So the first paper I wanted to publish is pretty old. It's from August of 1998, and it's titled "Aspirin and Salicylate Induced Apoptosis and Activation of Caspases in B-cell chronic lymphocytic leukemia cells." And I in particular wanted to highlight the right side of the screen here. And it says, although we have only observed effects on aspirin and salicylate on apoptosis of B-cell lymphoma cells at relatively high concentrations, 1.5 to 10 millimoles per liter, the lower range of such concentrations is achieved and even maintained in the treatment of chronic inflammatory states such as rheumatoid arthritis, in which therapeutic plasma concentration is 150 to 300 micrograms per liter, or about 0.94 to 1.88 millimoles per liter. Unfortunately, not all patients are able to tolerate the adequate dosage to maintain these plasma levels for a long period of time. And you know, I graduated medical school in 2014. And so by the time that I had graduated medical school, we were on to the next things, to treat rheumatoid arthritis. And so we were onto these DMARDs, and now there's like monoclonal antibodies and so on and so forth that we use. And so this paper is from, 15 years before I graduated medical school, when there was a time when we were using, possibly high doses of aspirin as a way to treat RA. So I can't say that I had really seen what the dosing strategy would be like for RA. So I went to, one of my major resources and tried to figure out what that may be. So as you can see here, when you look at the dosing regimen for aspirin, it's somewhere between 4 and 8,000 milligrams, or 4 to 8 grams per day, in 4 to 5 divided doses as needed. Titrate dose based off response and tolerability. Continue treatment until symptoms resolve, 1 to 2 weeks, potentially up to 8 weeks. And use of aspirin at these high doses, 4 to 8 grams per day, may be limited by adverse effects, tinnitus or ringing of the ears, diminished auditory acuity, like basically hearing loss, or GI intolerance. And I think that the way I would look at GI intolerance is probably going to be, possibly the causing of gastritis or, peptic ulcers or something like that, like a lot of the other NSAIDs do. So definitely not all roses, but these doses are huge per day, and they can probably be tolerated in the right patient for at least a couple of weeks, upwards of 8 weeks at a time. So, okay. And then what I was also able to find, again, looking through the literature, and this was not easy to find, but the therapeutic range for aspirin is typically between 10 and 30 milligrams per deciliter, which ends up being 0.725 to 2.17 millimoles per liter. And if you can remember, most of the studies that were using aspirin had, I believe that had 3 arms. It had like a 2.5 millimoles, a 5 millimoles, and a 7.5 millimoles. And definitely it seems, from what we'll see next, that anything above about 2.17 millimoles is likely going to be dangerous and unable to be achieved. But it's also pretty darn close to the 2.5 millimoles. And if you looked at some of those studies where they were combining like other nutrients with the lower dose of aspirin, you were seeing profound effects. So my point by sharing this is that it's possible that we can almost achieve some of the therapeutic ranges that are seen in some of those studies. And again, this is not going to be forever. Maybe even like, maybe it would even be pulsed, kind of like, like Dawn, where you like would do a week on, week off, or like 2 weeks on, 2 weeks off, kind of like DCA and 2DG and things like that. So my point is that it's possible that we can achieve those therapeutic dosages. Now, going further, it says that, like I said, the therapeutic concentrations vary significantly depending on the individual. A range of 2.8 to 20 milligrams per deciliter, 0.2 to 1.45 includes an effective serum concentration for many patients. However, some individuals are best treated at concentrations outside this range. So again, this is like another way to look at the effective dose depending on the condition and the patient. And so, and then the upper end of normal, which would be 30 milligrams per deciliter, which is at 2.17, like it talked about in this last little bit here, is kind of the upper limit of where we want to put it, because anything greater than that are often associated with toxicities, and we don't want that. Obviously, do no harm, right? But it just seems like that maybe we can almost achieve what they were doing in vitro, in vivo potentially, and it would be hopefully in combination with other things that would have an additive effect to it. Now the question is, what happens? So remember, in order to achieve this, 2.17, let's say, or 2 millimoles, you're taking like multiple grams of aspirin per day, okay? But what happens when aspirin is given to patients with cancer at ultra low doses, or comparatively speaking, ultra low doses, like a factor of 10? Well, let's take a look, because there's actually been quite a few studies on this. So probably the most powerful study was this study here, which was a systemic review and meta-analysis of 118 observational studies of aspirin in 18 different cancers. And it says, in order to test the hypothesis that aspirin taking is associated with an increase in survival of patients with cancer, we conducted a series of systematic literature searches to identify clinical studies of patients with cancer, some of whom took aspirin after having received diagnosis of cancer. And it says 3 literature searches identified 118 published observational studies in patients with 18 different cancers. 81 studies reported on aspirin and cancer mortality, and 63 studies reported all-cause mortality. Within the total amount of within a total of about 250,000 patients with cancer who reportedly taking aspirin, represented a 20 to 25% of the cohort. We found aspirin to be associated with reduction of about 20% of cancer deaths, with similar reductions in all-cause mortality of about 20%. So then that begs the question, well, in all these 118 studies and 18 different cancers, what kind of doses were they taking? Well, we're gonna take a look at that. So the next paper was a kind of a look back and adjustment of that last paper that was published in 2021. It says aspirin and cancer treatment, systemic reviews and meta-analyses of evidence for and against. And this is published in January of 2024, excuse me. And I went in the paper and actually looked at some interesting data points. And it said, as of January 2024, it says that there appears to have no systemic literature search and meta-analysis of clinical data on metastatic cancer, but many studies and overviews give evidence of substantial reductions by aspirin ranging in about the 52% reduction. If you take aspirin, having 52% less chance of having metastatic spread. It later says on survival, it says a number of different studies, statistics of survival have been used, and these defy pooling by giving an additional survival range of about 3 months up to 3 years. And what it said later is it said that entering in the formula, the details for a typical non-diabetic patient, age 70 with colon cancer, the inclusion of aspirin increases the estimate of survival by 5 years for a man and 4 years for a woman. So 70-year-old male or a 70-year-old female that's non-diabetic, adding aspirin added 5 years of survival to a man and 4 years to a woman. Pretty unbelievable considering colon cancer is extremely common. So I thought that was pretty interesting. And when you actually went to the conclusions of the paper, it says a major strength of the case for the promotion of aspirin is a treatment of cancer lies in the consistent evidence of reduction in thromboembolic complications of cancer and in consistent evidence of a reduction in metastatic spread. The main weakness, however, lies in the lack of support of a reduction in deaths from trials with random allocation of aspirin. So basically there's no randomized controlled trials is what they're saying. That's what they're saying the weakness is. Even though they have like tons and tons of other evidence, they're saying that they want it to be a randomized controlled trial. However, the suggested evidence from observational studies together with evidence of the Mendelian randomization powerfully favor the use of low-dose aspirin. We're going to talk about what the quote-unquote low-dose aspirin means in the next study. Finally, aspirin is inexpensive, readily available, and none of the highly aggressive side effects of some of the cancer treatments. It would therefore seem to be only fair and reasonable that knowledge of the true risk and probable benefits of the drug should be widely publicized among cancer patients and their carers, so that the oncologist has predicted, as one oncologist predicted, there could be benefit both to the affluent and to the indulgent within developed and underdeveloped countries, and a truly global impact on cancer mortality could be realized. Pretty powerful language from something as simple as aspirin. Now, this is a more recent study from January of 2025, nearly February of 2020, January 27th. And it says here, it's titled, Low-Dose Aspirin to Reduce Recurrence Rate of Colorectal Cancer Patients with PI3K Pathway Alterations, 3-year results of a randomized placebo-controlled trial. So these are the key findings from this study. It says, when compared to placebo, patients in both groups were less likely to have their cancer grow or change over 3 years if they took aspirin. Patients in group A had 51% lower risk of cancer recurrence when compared to placebo. The rate of recurrence in this group was 7.7% and compared to those who did not take aspirin and placebo of 14.1%. Patients in group B had a 58% lower risk of cancer recurrence when compared to placebo. This rate was 7.7% in those who took aspirin and 16.8% in those who did not take aspirin. The benefit of taking aspirin was seen in all groups, no matter what type of driver alteration change in the PI3K pathway they had. Groups A and B combined, patients who took aspirin were 55% less likely to have their cancer reoccur than those who took a placebo. Now, this begs a couple of questions. Who the heck is group A, and who the heck is group B, and what is low dose aspirin? Well, I had to dig into the methods to figure that out. So the patients that were in any group had either stage 1 to 3. They did not have metastatic prostate cancer. They had 1 to 3 or 2 to 3 colon cancer exhibiting somatic alterations in the PI3K signaling pathway. So basically, they had a genetic mutation of the PI3K AKT mTOR pathway. Patients were randomized to either receive 160 milligrams. So that's super low dose compared to what could be, right? When we're looking at those high concentrations, we're trying to achieve looking at ways to inhibit the PFK enzyme. 2.5 millimoles, probably not going to be achievable, but 2.17 is. Giving gram quantities. We're talking 8,000 milligrams, 4,000 to 8,000 milligrams of aspirin per day. But these patients were not getting that. They were getting a measly dose of 160, which for most patients are getting 81 milligrams per day, maybe 325. But again, it just skews our view because my view of aspirin, a high dose would be 325, a low dose would be 81. In this case, they're calling low dose 160. Anyway, I just want to put that out there because low high is kind of subjective, right? So rheumatologists from the 90s probably see 160 as ultra low dose if they were giving that amount of aspirin for an RA flare, right? So my point is that they were getting randomized to either 160 milligrams of aspirin daily or placebo, initiated within 3 months post-surgery and continued for 3 years. So they got 160 daily or placebo for 3 years. And they had group A, which was PI3K mutations in this exon 9 or exon 20. And there's 150 people from there, and then 300 people from group B, which was PI3K driver alterations outside of 920. And that was group B. So basically, just going back to the findings here. So basically, these are people who have mutations in PI3K, AKT, mTOR pathways, and they either had one type of genetic mutation that affected that pathway, or another mutation that lowered that pathway. Okay, and essentially they had a overall combined 55% less risk of developing progression of disease and metastatic spread, which I think is pretty unbelievable. Now, remember, at that low dose, most of medicine is going to believe that the major effects is going to be on the inflammatory pathways and potentially this PI3K, AKT, mTOR pathway. As we saw in the prior video, there are multiple pathways that are affected by aspirin. And the question is PFK at all contributing here? The answer is we don't know. My gut tells me that probably is having a minimal effect, given that it had such high concentrations to have the effect in vitro, but it doesn't mean that it doesn't have a clinical benefit, right? So my point by showing you all this is that number one, aspirin's pretty cheap and pretty safe, and obviously talk to your doctor before starting any medications, and it can be pushed up to high doses for a period of time, likely based off of old treatment protocols for rheumatoid arthritis. And we can almost achieve those concentrations that mimic those in vitro studies. That being said, it may not require that level of aspirin concentrations to have a clinical benefit. And we can obviously see that from these giant, meta-analyses and systemic reviews of 118 studies, 18 different cancers, showing a pretty decent 20% drop in cancer-related mortality overall. And then when studied even further for colorectal cancer, 51% and 58% reductions in recurrence at a very low dose. So, I think that the answer is going to be probably somewhere in the middle, where if you go, there may be a dose response. And I think this would be an interesting study for them to do, is for them to take, okay, group A is 150 or 160 milligrams of aspirin per day, go up to 325, go up to 650, and start pushing it up towards that, upper limit of what a person can tolerate for a period of time, and then look at what the outcome would be for them. But we don't have that data. This is the most recent data. And remember, this is even a January 2024. There was no randomized clinical trials on aspirin at that time. So this is kind of like one of the first ones that was used, first clinical trials that was done, which was January 2020, or let's see here, January 27th of 2025. So just a couple months ago. So still needs to be learned, but I wanted to put that in there because there was kind of a lot of, I don't want to use the word clamoring, but there was a lot of like pushback about, well, how is this relevant to people, because they're not able to achieve those concentrations, which I can see that it's going to be probably impossible to achieve 2.5, definitely impossible to choose 5 or 7.5 millimoles. But can you get to that threshold of 2, combining with other things like other phytochemicals that you saw in those previous in vitro studies showing a synergistic effect, and even surpass these studies done with much lower doses of aspirin? My gut tells me that it's possible that it could, but we need to have more studies, to be able to for sure say that, or at least like observational studies, so of people trying it. Anyway, I hope that was helpful. Now, to the main event here, talking about PFKFB, which stands for, and I'm only going to say this a couple of times because it's a very long name, but 6-phosphofructo 2 kinase fructose 2,6-biphosphatase 3. And this is an enzyme that was somewhat alluded to in the prior video on PFK. And if you remember right, PFK is here again. And what we're seeing here is that PFK is highly influenced. In fact, it's the most influential activator of PFK is the product of this particular enzyme, PFKFB. So let's go into what the heck this is and how it's important for cancer. So the first paper I'm going to talk about is published in February of 2021, and it's titled "The Role of PFKFB and PFKFB4, PFKFB3 and PFKFB4 in cancer: genetic bias or genetic basis, impact of disease development, progression, and potential as therapeutic targets." And it says glycolysis is a crucial metabolic process in rapidly proliferating cells such as cancer cells. Phosphofructokinase 1, PFK1, is a key rate-limiting enzyme of glycolysis. Its efficiency is allosterically regulated by numerous substances, including occurring in the cytoplasm. However, the most potent regulator of PFK1 is fructose 2,6-biphosphate, the level of which is strongly associated with this PFKFB. PFK2, FB2, is a bifunctional enzyme responsible for F26BP synthesis and degradation. There are 4 isoenzymes of PFKFB, 1 through 4, that have been identified. Alterations in the level of PFKFB isoenzymes have been reported in different diseases. However, most recent studies are focused on an increased expression of PFKFB3 and 4 in cancer tissues and their role in carcinogenesis. In this review, we review the current knowledge of all PFKFB genes and protein structures and emphasize important differences between the isoenzymes, which likely affect their kinase/phosphatase activities. The main focus of the latest reports in the field of cancer research, and in particular the impact of PFKFB3 and 4 on tumor progression, metastases, angiogenesis, and autophagy. So let's take a look at the first kind of graphic we have, looking at what could be going on here. So we have glucose. Glucose is going to get into the cell via the glucose transporters. It's going to get converted to glucose 6-phosphate via hexokinase or HK2. It's going to get converted from glucose 6-phosphate to fructose 6-phosphate via phosphoglucose isomerase. One thing that is not shown here, which will be readily apparent in the next video or the next couple of slides, will be that glucose 6-phosphate has two major fates. It can go to fructose 6-phosphate and continue on through glycolysis to make energy for the cancer cells, right? Through the Warburg effect. Or it can also be the first substrate used by G6PD as part of the PPP pathway, pentose phosphate pathway, and can do other important things for the cancer cells and normal cells. But we see here that fructose 6-phosphate can be converted to fructose 2,6-biphosphate by PFKFB3, and then that product of that fructose 2,6-biphosphate is the strongest activator of PFK1. Okay, we see a plus sign. It's the strongest known activator of PFK1. So because it's activating PFK1, it's going to allow Warburg metabolism to continue, as well as a bunch of other things. So the question is there a role in trying to inhibit PFKFB3 and lower the amount of fructose 2,6-biphosphate as a target for cancer, as a way to lower the amount of PFK1 that's actually active? That's basically the question we're trying to answer and look at in this particular video. Next paper, published in February of 2019. And it says 6-phosphofructo-2 kinase fructose 2,6-biphosphatase 3 and 4, a pair of valves for fine-tuning glucose metabolism in human cancer. And it says here, cancer cells favor the use of less efficient glycolysis rather than mitochondrial oxidative phosphorylation to metabolize glucose, even in oxygen-rich conditions. A distinct metabolic alteration named the Warburg effect, or aerobic glycolysis, or substrate-level phosphorylation. In adult cells, bifunctional, I'm just going to say PFKFB family members, are responsible for controlling the steady-state cytoplasmic levels of fructose 2,6-biphosphonate, which allosterically activates PFK, the key enzyme catalyzing the rate-limiting reaction of glycolysis. PFKFB3 and 4 are the two main isoenzymes overexpressed in various human cancers. Scope of review. In this review, we summarize recent findings on the glycolytic and extraglycolytic roles of PFKFB3 and 4 in cancer progression, and discuss potential therapies for targeting PFKFB3 and 4. Major conclusions. PFKFB3 has the highest kinase activity to shunt glucose towards glycolysis, whereas PFKFB4 has more FBPase2 activity, redirecting glycolysis or glucose towards pentose phosphate pathway, providing reducing power for lipid biosynthesis and scavenging reactive oxygen species. Co-expression of PFKFB3 and 4 provides sufficient glucose metabolism to satisfy the bioenergetics demand and redox homeostasis required of cancer cells. Various reversible post-translational modifications of PFKFB3 enable cancer cells the flexibility to adapt to glucose metabolism in response to diverse stress conditions. In addition to playing important roles in tumor glucose metabolism, PFKFB3 and 4 are widely involved in multiple biologic processes such as cell cycle regulation, autophagy, and transcriptional regulation of the non-glycolysis dependent manner. So that's a lot that is said about these two enzymes. But this next couple of pictures is going to solidify exactly what's happening here, okay? So as the paper is titled, a pair of valves for fine-tuning glucose metabolism in human cancer. So we have a picture of a yin and yang here, and we see that the demands of the cell is going to dictate where glucose is being shunted towards. So as I alluded to in this particular graphic, I said between here, glucose 6-phosphate has another fate. It can go into the PPP and it can have important roles there. So this is what this graphic is actually showing us. So we see here that glucose, again, via hexokinase, glucose 6-phosphate to fructose 6-phosphate. Here's our PFK1, which we've been talking about the last couple of videos, PFK1. And PFK1 is responsible for the next level of change to fructose 1,6-biphosphate. However, these PFKFB enzymes, both 3 and 4, are in the middle that are fine-tuning to know where glucose should be put depending on the needs of the cancer cell. So, for example, for rapid growth, PFKFB3 will be activated, and F26-biphosphonate will turn on PFK1, which will allow all the glucose to be shunted towards lactate, which will lead to energy production. Okay, we need lots of energy for cell growth, and the lactate will acidify the tumor microenvironment and lead to metastatic spread. However, if there are a lot of reactive oxygen species and oxidative stress going on, or there's a need for lipid or nucleotide, which are DNA and RNA synthesis, or if there's, like I said, a lot of redox imbalance, then PFKFB4 will kind of take over, and it'll reconvert this F26BP back to fructose 6-phosphate and allow it to be used in the PPP, or the pentose phosphate pathway, so that we can recycle NADPH, and we can help glutathione be recycled, and we can restore glucose redox homeostasis. Okay, so let me give you an example. So let's say hypothetically, you did not have an understanding of Seyfried's framework of metabolic therapy. You were not minding your glucose or glutamine. But you were interested in alternative cancer treatments, and you had been exploring hyperbaric oxygen or ozone therapy or IV vitamin C, and you were hitting it with oxidative stress, and you were depleting cancer cells glutathione by doing that. What would happen is that this PFKFB4 would say, hey, we have a lot of redox imbalance. We need more reducing molecules like NADPH to help recycle glutathione, to help keep up with that and maintain redox homeostasis. Therefore, it would shunt the glucose towards that pathway. Whereas if the energy of the cancer cells was low, or the tumor microenvironment was inhibiting rapid growth and metastatic spread, then perhaps PFK3FB would be taking over, and therefore leading to more ATP production through aerobic glycolysis, lactate production, and ultimately the tumor microenvironment, which has multiple factorial reasons, including leading to chemotherapy resistance and immunotherapy resistance. So my point is that this is the relief valves, or the control valves of the Warburg effect and the PPP that are being controlled by these isoenzymes of PFKFB. I hope that helps at least understand why this could be a very important target for therapies potentially. Now the question is, what is regulating PFKFB3 and 4 activity? Well, the answer is a lot. Okay, so I'm going to do a video on why we care about ER/PR positive for breast cancer. Why do we care about EGFR and HER2? Why do we care about androgen receptor for prostate cancer? Why do we care about c-MYC or RAS or all these other things? Because they're made, they kind of, I don't want to say overcomplicate things, because biochemistry and cell biology is very complex. That I don't disagree with, but where do they kind of like all have similarities, okay? The answer is the Warburg metabolism, okay? The Warburg metabolism is set up by all of these different metabolic pathways. So let's take a look here. Here's PFKFB, okay? We see that it's influenced by hypoxia-inducible factor 1. It's influenced by estrogen receptor and progesterone receptor, and by sex hormones, progesterone and estradiol, as well as you would see here likely androgen receptor as well. Cortisol and other stress stimuli, inflammatory cytokines that work through a variety of pathways, hypoxemia, hyperglycemia, growth factors such as EGFR. We'll also see that VEGF, or vascular endothelial growth factors, multiple things, insulin, etc., will all have upregulatory roles on PFKFB3. And what that's going to do, that's going to it's going to be one way that those stimuli will upregulate the Warburg metabolism. Okay. Now there are various ways that it does it, but my point is this is one way that all of these different types of cancers, all of these different types of what do you want to say, abnormalities that are found for, let's say, breast cancer, HER2, this is EGFR, right? Or if it's ER, PR positive, there coalesces with this. But it all kind of funnels into, all these pathways will upregulate the use of glucose as a metabolite in a variety of ways, or glutamine, as you'll see. So my point is that why do we care about those things? Because it ultimately does this, okay? It's going to be stimulated by a variety of different ways. It's kind of like a lot of different ways getting to the same result, upregulating glycolysis and feed forwarding the Warburg effect and Warburg metabolism. This is a paper that I pulled from 2003. This enzyme has been known about for a long, long time, obviously. And hypoxic regulation of 6 of these PFK 1 through 4 enzymes. And it says, previous work demonstrated that PFK2 isozyme genes, PFKFB3, was induced by hypoxia through hypoxia-inducible factor 1 pathway. In this study, we examined the basal and hypoxic expression of 3 members of the family of different organs in mice. Our findings indicate that all 4 isoenzymes are responsive to hypoxia in vivo, or hypoxic signals, which is, that can also be triggered by pseudohypoxia, which we've talked about a year ago. As a matter of fact, when I did the series on hypoxia-inducible factor, I have about 3 videos on that. So my point is that either hypoxia or pseudohypoxia can upregulate hypoxia-inducible factors. And then hypoxia-inducible factors will upregulate PFKFB, which will lead to the Warburg effect, right? What else? Well, how about hyperglycemia? Hyperglycemia induces PFKFB3 overexpression and promotes malignant phenotype of breast cancer through RAS-MAP kinase. So that's kind of like looking at, where is it? Actually, it may not be on this paper, but the bottom line is you're seeing other pathways that are not even on this paper, which is already pretty comprehensive. So hyperglycemia can upregulate this. And what it says here is that diabetes mellitus has been reported to positively regulate the development of many tumors. However, the specific mechanisms of hyperglycemic environment regulating breast cancer remains unclear. PFKFB3 is a key regulatory factor of the glycolytic process in diabetes mellitus, as well as promoter of breast cancer. So we want to explore the potential links between PFKFB3 and the poor prognosis of breast cancer patients with hyperglycemia in this study. The results show in this study, we demonstrated that the expression of PFKFB in breast cancer complicated with hyperglycemia was higher than that of breast cancer with euglycemia through the cell experiment, in vitro, and histologic experiment. So basically, they found that if you have higher levels of PFKFB3 with hyperglycemia, you had worse prognosis than if you had a normal amount of blood glucose. PFKFB3 overexpression decreased the survival period of breast cancer patients and was correlated with a number of clinical pathological parameters of breast cancer complicated with diabetes. PFKFB3 promoted the proliferation and migration of breast cancer in a hyperglycemic environment and might be regulated by this MIR26. In addition, PFKFB3 stimulated the epithelial mesenchymal transition of breast cancer in the hyperglycemic environment. In terms of downstream mechanism explored, we predicted that this verified cancer-promoting effect of PFKFB3 in breast cancer complicated by hyperglycemia through the RAS/MAPK pathway. So hyperglycemia, we know, will worsen prognosis of cancer. And it makes total sense when you look at cancer as a metabolic disease, a mitochondrial metabolic disease. But that being said, they're looking at kind of like what pieces in particular are responsible for that. My gut tells me it's more than just PFKFB3, but this is at least one major reason for why there's a worse prognosis with breast cancer with hyperglycemia, because it upregulates and overexpresses that enzyme. What else does it? Well, how about insulin? Insulin induces PFK3FB gene expressed in HT29 human colon adenocarcinoma cells. Fructose 2,6-biphosphate is present in high concentrations in many established lines of transformed cells. It plays a key role in the maintenance of high glycolytic rate by coupling hormonal and growth factor signaling pathways with metabolic demand. The concentration of fructose 2,6-biphosphate is controlled by the activity of the heterodimeric bifunctional enzyme PFKFB. We report that PFKFB3 gene expression controlled by insulin in human adenocarcinoma cell line. The incubation with these cells with 1 micromole of insulin resulted in an increase of PFK2 mRNA expression after 6 hours of treatment. This effect being blocked by actinomycin D. Furthermore, insulin-induced ubiquitous PFK2 protein levels that were evident after a lag of 3 hours and could be inhibited by incubation with cyclohexamide. So, these researchers are saying that cancer for this breast cancer model is likely due to PFKFB due to hyperglycemia. Other models would suggest that it's the insulin. My point is that when you're stressed, when you have excess amounts of estrogen and progesterone, when you have excess amount of inflammation, when you have hypoxic and pseudohypoxia, when you have hyperglycemia, when you have excess growth factors, and it's going to be a team approach, okay, at increasing this. And the entirety of Warburg metabolism and enhanced glutaminolysis. So my point is that although we're looking specifically at PFKFB as being playing a very important role here, looking at it from one particular angle, it's likely going to be multiple things that are affecting this. So don't get sucked into, if I lower my insulin, I'm going to be fine. No. Lower glucose can be fine. No. It's going to be lowering as many things as we know that can affect these pathways. Here's another paper looking at c-MYC having an effect on these pathways. There's another paper that I found showing the canonical and non-canonical roles of PFKFB in brain tumors. So we've looked at, I guess, what you consider the canonical roles of PFK and upregulating the use of glucose and converting into lactate, like we've seen here, right? It's going to upregulate PFK activity. Well, there's other roles that it has. It was kind of alluded to in this breast cancer paper when it was talking about the role of the epithelial mesenchymal transition. But you'll see here that the normal role would be glycolysis of PPP. But then it also has effects on the cell cycle, on the making of new blood vessels through angiogenesis, and the inhibition of DNA repair. And then later it talks about how RAS and transforming growth factor 1 beta 1 all are responsible for upregulating the PFKFB enzyme, which ultimately leads to enhancement of the Warburg metabolism, and how it basically makes, basically gliomas more likely to be, aggressive and so on and so forth. So this is a protein and an enzyme that is, seen in probably every human cancer, because it's in every normal cell as well. and it provides that relief valve. The issue is that the cancer cells are relying on glucose as their main source of energy. So therefore, an enzyme like PFKFB, as well as PFK and hexokinase and all these, are going to be magnified in terms of their importance in these cancers compared to normal cells. The conclusion of that paper, with talking about brain cancer and PFKFB, recently Faubert et al. Explained the importance of metabolic therapy in tumor genesis. Although a century ago, Otto Warburg and his colleagues noted increased glucose consumption in the production of lactate in tumor cells compared to non-proliferating normal cells, since then, the aerobic glycolysis phenotype has been regarded as a hallmark of cancer and is termed the Warburg effect. Most tumors have a hypoxic microenvironment because of the poor perfusion from abnormally formed tumor blood vessels, while when oxygen levels are depleted, HIF-1 alpha regulates the shift from oxidative metabolism to aerobic glycolysis. These hypoxic-driven glycolytic preference further stimulates the tuberogenic microenvironment through cellular secretion of lactate. Elevated lactate and the surrounding environment diminishes chemotherapeutic delivery while stimulating tumorigenic angiogenesis via the activation of HIF-1 alpha-mediated upregulation of VEGF, vascular endothelial growth factor, FR2. TMR is essential for tumor microenvironment, I'm guessing is what that stands for, is essential to tumor genesis, and it allows for a consistently high rate of glycolytic flux to be maintained. HIF-1 alpha activates a multitude of oncogenic signaling pathways, one of which is PFKFB3 induction. PFKFB3 has the highest kinase activity of all the PFKFB isoenzymes, and there is thus able to sustain continuous glycolysis through elevated F26P2 levels. Constant F26P2 levels override the mechanisms that normally control glycolytic flux. Thus, intracellular concentrations of F26P2 in cancers is primarily maintained by PFKFB3, allowing cancer cells to evade glycolytic suppression. In addition to providing continuous energy for uncontrolled proliferation, glycolytic TMR is responsible for chemoresistance and radioresistance in a variety of cancers, including malignant CNS tumors such as glioblastoma. In addition to glycolytic rewiring, PFKFB3 is complicated by an angiogenesis, continuous cell cycle progression, and cancer cell DNA repair. PFKFB overexpression has been associated with a poor prognosis in various neoplastic diseases. In brain tumors, including high-grade gliomas, PFKFB3 expression has been linked to a poor survival. However, targeted PFKFB3 inhibition may provide a therapeutic option for CNS tumor patients. PFKFB3 inhibitor therapy has been observed to restore chemosensitivity and radiosensitivity in treatment-resistant tumors. Combined with anti-PFK3 and anti-VEGF therapy has been noted to improve the survival of glioblastoma preclinical models and abrogate resistance to anti-angiogenic therapy. The use of PFKFB3 inhibitors has synergistic effects with chemotherapeutic and radiotherapeutic modalities via mitigation of TMR, promoting antitumor cytotoxic prolonging TBN and modulating immune suppressive cells, and improved understanding of PFKFB metabolic and extrametabolic functions and the relation of tumorigenicity may allow for the development of targeted therapy as a means of modulating its various oncogenic behaviors. That's a lot. So what are they seeing when they give a PFKFB inhibitor? Number one, they're restoring chemotherapy and radiotherapy sensitivity in previously resistant tumors. So it's reversing chemoresistance and radioresistance. It also will shut down to some degree the new blood vessels that are created, and it will also any resistance to those like a VEGF inhibitor will be restored. It will also modulate the immune system, so they allow the immune system to actually attack the cancer cells. It makes total sense because, let's just take a look at some kind of a model here. Let's see if I can find it. I'm just looking at a picture that makes sense here, you guys. So here we go. So we have glucose. It's being converted to lactate, right? Actually, it doesn't actually show it here, but the bottom line is we see lactate excreted, right? So the end product of glycolysis is lactic acid, and lactic acid is going to be excreted into the tumor microenvironment, and that's going to decrease our immune system's ability to attack the cancer cells. So therefore, if we shut down PFKFB and the amount of glycolysis is downregulated and the amount of lactate that is made is lowered as well, obviously that would decrease the viability of the tumor microenvironment and allow for the immune system to kind of turn on and start killing cancer cells. Bottom line is, just this one protein, PFKFB3, could be extremely promising. Now the question is, do we have any inhibitors of this? So this paper was published in November of 2016, and it says inhibition of PFKFB3 suppresses the glucose metabolism and growth of HER2 positive breast cancer. Human epithelial growth factor receptor 2, HER2, has been implicated in the progression of multiple tumor types, including breast cancer, and many downstream effectors of HER2 signaling as our primary regulators of cellular metabolism, including RAS and AKT. A key downstream metabolic target of RAS and AKT is the PFKFB3, whose product F26BP is a potent activator of PFK. We've talked about that multiple times now. We postulate that PFKFB3 may be regulated by HER2, which we've also seen, and contribute to HER2-driven tumorigenicity. It says here, PFKFB3 is elevated in human HER2 positive breast cancer, and high PFKFB3 transcript correlated with poorer progression-free survival and distant metastatic-free survival. Constitutive HER2 expression led to elevated PFKFB3 expression and increased glucose metabolism, while inhibition of PFKFB3 suppressed glucose uptake, 2,6-BP glycolysis, and selectively decreased the growth of HER2 expressing breast cancer cells. In addition, treatment with ladininib, an FDA-approved HER2 inhibitor, decreased PFKFB3 expression and glucose metabolism in HER2 positive cells. In vivo administration of PFKFB3 antagonists significantly suppressed the growth of HER2-driven breast cancer tumors and decreased the F2 deoxyglucose uptake, or the PET scan uptake. Taken together, these data support the potent clinical utility of PFKFB3 inhibitors as chemotherapeutic agents against HER2-positive breast cancers. So let's demystify HER2. What is HER2 effectively doing? HER2 is a growth factor that is upregulating the machinery responsible for glycolysis. So we can just call it growth factor, right? It's going to upregulate the machinery for glycolysis, including PFKFB3. So if we inhibit PFKFB3, the overactivation of HER2 is diminished substantially. Or if we block HER2, we see that PFKFB3 is downregulated and therefore also diminishes the tumor growth. So again, I'm trying to demystify ER/PR positive, HER2 positive. They all work through glycolysis, okay? It just goes to show that we have very likely overcomplicated cancer, okay? Cancer ultimately relies on glucose, and it relies on glutamine, and it relies on that lactate to be shunted outside the cell so it can set up the tumor microenvironment. The external shields. The internal shields are the glutathione production, right? The glutathione production that is also controlled by PFKFB4, because it's going to shunt glucose towards the PPP to make and protect the cell from redox imbalance and restore redox homeostasis. But it all requires glucose and glutamine. So my point is that it doesn't really matter, and it just goes to show it doesn't matter at all if you have a PR positive or an ER positive or a HER2 positive or a triple negative or a whatever type of cancer you have, a glioblastoma or a colon cancer or whatnot, they all require glucose and glutamine. And they all utilize these very specific mechanisms in order to force feed the use of glucose for these cancer cells. So now we're going to get into treatment of cancers using PFKFB3 inhibitors. And unfortunately, you guys, I'm already an hour in and I've got at least another 12 slides. So I'm going to take a look at the comments here and look at to see if there's anything that's that I can answer so far. So good morning, other people. Have you come across the med paper about frankincense essential oil? So I don't know if I've come across the paper specifically that you're talking about. I can say that Boswellia, the kind of major ingredient of frankincense oil, is a powerful anti-inflammatory, and it would make sense that it would have a role. The question is, does it have a role at specifically inhibiting any of these glucose or glutamine pathways? I would say probably indirectly through inflammation, but I don't know. And I would say that it's probably going to be some help with it. It's just that I haven't seen that particular paper. Paul, thank you so much for your support. Greetings from Switzerland. Well, greetings from Florida. Excellent walkthrough, Dr. Peebler. Thank you very much. Well, there's not a whole lot of activity today on the comments. So, I guess the question is, should I keep going or should I leave you guys in suspense of what the particular PFKFB inhibitors should be? I would say that not to leave you in suspense, but I think that we've gone an hour already. So why don't we cut it off? We now, at this point, understand what PFKFB is, the fact that it has 1 to 4 isoenzymes, 1 to 4. PFKFB3 and 4 are the most ubiquitous within cancer. We also know that PFKFB is kind of a on and off switch, right? So if the cancer cell needs energy, it's going to be activating PFKFB3. If the cancer cell needs help with creating new molecules like lipids or nucleotides and DNA and RNAs, or probably more acutely, the need for redox homeostasis, PFKFB4 will shunt glucose 6-phosphate towards the PPP so that we can upregulate NADPH and help glutathione recycle, so therefore maintain glucose homeostasis and really upregulate that internal shield system of the cancer cells, which makes cancer more resistant to radiotherapy, chemotherapy, etc. Whereas the creation of lactate, the acidification of the tumor microenvironment creates the external shields against our immune system, against immunotherapy, chemotherapy, and even radiotherapy as well, and promotes metastatic spread. So these PFKFB4 is quite important. And again, it has a positive enhancement of PFK, the PFK enzyme, which again, we looked at in a fairly recent video here, right? Where we were looking at multiple things that were having effects on that particular enzyme, PFK, as being one of the key rate limiting enzymes within cancer. Well, PFK3FB is responsible for making 2F26BP, which is the strongest activator of this PFK enzyme, which allows glucose to be shunted towards lactate and to further the Warburg effect. So we've also seen where PFKFB is upregulated by stress signals, inflammation, progesterone, estrogen, HER2, other growth factors, insulin, hyperglycemia, hypoxia, pseudohypoxia, et cetera, et cetera, et cetera. All things that have effects on probably every single human cancer, including breast cancers, including colon cancers, including CNS, high-grade gliomas, glioblastomas, et cetera. And now that we know the importance of this enzyme and how it functionally works to maintain the Warburg effect, to maintain redox homeostasis for the cancer cells, and how it's kind of hijacked by all these growth signals and all these pathways, We now are going to talk about in the next video how it is inhibited by a variety of natural and drug inhibitors. And I will say that there's not near enough work done on this target, on PFKFB3, but I do think that this is going to be an important target for us treating cancers and metabolic disease, but also for conventional medicine as well. With that, I will sign off, and I'll say that if you like videos like this, please like it. If you have anybody in your life who is struggling with cancer, who could use information like this, who needs, I would say, as close to evidence-based, rationale for the metabolic theory of cancer, we're laying it out day in and day out on this channel. Yes, we're using technical language. Yes, we're using big words, and it's going to take a lot of effort on your part. The good thing is our series it builds in itself. The series started about a year ago, and it grows and grows and grows. And as my understanding increases, and I can present it to you, hopefully your understanding will increase. And there's a lot of repetition. And what I'll say is it's not easy to grasp, but it's just better to stick to the literature when talking about kind of, outside the box thinking when it comes to treating cancer. And what I'll say is if you have anybody that in your life who needs this information, please share it with them. And until next time.